Hello, today we are going to learn about a module. The module is of factors affecting protein binding of drugs. Myself Prashant Nayak, Assistant Professor, Department of Pharmaceutics, NGSM Institute of Pharmaceutical Sciences, Mangalore. What are the learning objectives? Today we will see the different factors, what are responsible, what affect the protein binding of drugs. There are various factors which we'll look into. So coming to the factors, they are broadly classified as drug related factors. So when we say drug related factors, there will be a physiochemical characteristics of drugs. Then we will see how concentration of the drug in the body affects the protein binding, affinity of the drug for a particular binding component. The next factor is called as protein or tissue related factors. In this also we will see how physicochemical properties of proteins or binding agent happens. How the concentration of proteins or binding component affect the protein bindings. Number of binding sites which are there present on the binding agent. So these all things we will learn. The next one is drug interaction. So how there will be a competition between the drugs for binding sites, displacement interactions we call it as, competitive binding the drug and the normal body constituents. Allosteric changes what happens in protein molecule will be studied in detail. At the last we will see patient related factors. In this we will see a few examples how age affects the protein binding of drug, how there will be intersubject variations, and how a disease state affects the protein binding of the drug. What happens in a disease state? Now coming to the first factor, what is drug related factor? First one in drug related factor, as we said earlier, it is physiochemical characteristics of the drug. So as mentioned earlier, protein binding is directly related to lipophilicity of the drug. An increase in lipophilicity increases the extent of binding. For example, slow absorption of cloxacillin in comparison to ampicillin after IM injection is attributed to its higher lipophilicity and larger 95% of binding of proteins, while the later is less lipophilic and just 20% is bound to proteins. Highly lipophilic drugs such as thiopentol tend to localize in adipose tissues. Anionic or acidic drugs such as penicillin, sulfonamides bind to human serum albumin, whereas cationic or basic drugs such as imipramine, alpranolol bind to AAG. Neutral unionized drugs binds more to lipoproteins in the body. The concentration of drug, second factor in this, concentration of drug in the body. The extent of protein binding can change with changes in drug as well as protein concentration. Concentration of drug that binds human serum albumin does not have much of the influence as the therapeutic concentration of any drug is insufficient to saturate it. Concentration of lidocaine can saturate AAG molecules with which it binds, as the concentration of AAG is less in comparison to HAS or human serum albumin in blood. What is the drug protein tissue affinity? Lidocaine has great affinity for AAG than for HSA. Digoxin has more affinity for proteins of cardiac muscles than those of skeletal muscles or plasma muscles. Oxalic acid, a radiopaque medium, lupofenoxy acid, has so great affinity for plasma protein, then it has a half-life of 2.5 years. Now we will see what exactly is a protein tissue related factor. Under this, the first thing we will see is the physiochemical properties of protein binding component. Lipophilic or lipoproteins, adipose tissues tend to bind lipoproteins and adipose tissue tend to bind to lipophilic drugs by dissolving them in the lipid core. Physiological pH determines the presence of active anionic and cationic groups on the albumin molecules to bind a variety of drugs. So this is how it affects. Concentration of protein binding component. Among the plasma protein, binding predominantly occurs with albumin, as it is present in a higher concentration in comparison to other plasma protein. Amount of several protein and tissue components available for binding changes during disease state. This effect will be discussed in subsequent section. So number of binding sites on protein. Albumin is the large number of binding sites as compared to several other proteins and is a high capacity binding component. Several drugs are capable of binding at more than one site on albumin. Fluoxacillin, fibupropin, ketoprofen, tamoxifen, dicomironol bind to the primary and secondary sites on albumin. Now coming to drug interaction. Competition between the drug for binding site. Displacement interaction. When two or more drugs can bind in the same site, competition between them for interaction. With the binding site results, if one of the drug A, is bound to such a site, administration of another drug B has affinity for the same site results in displacement of drug A from its binding site. Such a drug-drug interaction for the common binding site is called displacement reaction, where we can say drug A is displaced by drug B. Drug A is called displaced drug and drug B is called as a displacer. So this is drug interaction because of competition. Now in this figure 1, which is taken from the reference 1 and 2, fate of drug after displacement interaction, we can see clearly in the blood the drug and protein binds together, then it is displayed. After displacement of the drug, it goes to either to the liver and storage tissue, or it goes to the site of action to the receptor. If it goes to the site of action, we can see enhanced pharmacological activity. If it goes to the storage tissue, we see tissue redistribution of the drug takes place. Now if the displaced drug goes to the liver, then it undergoes an hepatic clearance and gets eliminated. If it goes to kidney, then it goes to renal clearance and leads to elimination. So this is the fate of the drug in the displacement interaction, how it displaces. The competition between drugs and normal body constituents. Among the various normal body constituents, the free fatty acids are known to interact with a large number of drugs that bind primarily to human serum albumin. The free fatty acid level is increased in several physiological. When we say physiological, it can be fasting. Pathological, when we say it is diabetes, myocardial infarction, and alcoholism. And pharmacologically induced conditions after heparin injection or after caffeine administration. Fatty acids, which also bind to albumin, influence binding of several benzodiazepines and propranolol. Decreases binding and warfarin increases binding. So propranolol is the one in the presence of free fatty acids. It increases the binding. Propranolol decreases the binding, whereas warfarin increases the binding. Bilirubin binding to human serum albumin can be impaired by certain drugs, and it is of great concern in neonates whose blood-brain barrier and bilirubin metabolism capacity are not very efficient or not very well developed. Now we will come to allosteric changes in protein molecules. This is one another mechanism by which a drug can affect protein binding interaction. The process involves alteration of protein structure by the drug or its metabolite, thereby modifying its binding capacity. The agent that produces such an effect is called as the allosteric effector. Aspirin acetylates the lysine fraction of albumin thereby modifying its capacity to bind NSAIDs like phenylbutazone, increases affinity. Flunamic acid decreases the affinity. So this is how the capacity of NSAIDs like phenylbutazone increases the affinity and flupinamic acid decreases the affinity. These are all the changes which happens in allosteric changes within the protein molecule. Now coming to the patient related factors. Age. Modification in protein binding are influenced by age of patient. It is mainly due to the difference in protein content in various age groups. In the case of adults, in case of children, in case of infants, the protein level present will very effectively or it will cause a major factor for protein drug binding. Intersubject variations in drug binding are studied. With few drugs showed that there is a difference in small or no more than twofold decrease. The difference between has been attributed to genetic and environmental factors which occurs between patients, or we can say it can be within yourself. It will be an intersubject variability because of drug binding, disease state, several pathological conditions. What happens is there is alteration in protein content in the body, such as albumin. Since albumin is a major drug binding protein, hypoalbuminuria can severely impart protein drug binding. Now we'll see the influence in this table of the disease state on protein drug binding. A reference is taken from 1 and 2. Disease is a renal failure, uremia. What is the influence of plasma protein? We have a decreased albumin content. Then what exactly happens on protein binding? Decreased binding of acidic drugs, neutral and basic drugs are unaffected. So we can say decreases in binding in acidic drug is seen in renal failure. Hepatic failure decreases albumin synthesis. So decrease in binding of acidic drugs. Binding of basic drug is normal and reduced depending on AAG levels. Inflammatory states, trauma, surgery, burn, infection, increased of AAG level has been seen in plasma protein. Increased binding of basic drugs, neutral. So inflammatory states, trauma, surgery, infection, we can see the increased binding of basic drugs. Neutral and acidic drugs are unaffected. So today what we have learnt is what exactly are factors affecting protein binding from physiochemical properties till the disease state. We have seen how they influence patient related factors, factors related to protein binding, and how physiochemical properties these all alter the protein drug binding in the body. So that's all for now. This is taken from the references Shargil, Applied Biopharmaceutics and Pharmacokinetics, and Brahmankar and Jaiswal, Biopharmaceutics and Pharmacokinetics, Vallabh Prakashan. So that's all for now. Have a nice day. Take care. Bye.